Hello students, welcome to this experimental class on whiteboard animation. So in the last class we had discussed about leprosy. We had begun with epidemiological factors of leprosy such as agent factors, host factors and environmental factors. After which we had discussed mode of transmission as well as the incubation period of leprosy, and following which we had discussed about different classifications used in leprosy such as the Indian classification, Ridley-Joplin classification, as well as we also had discussed about the difference between multibacillary as well as paucibacillary leprosy. And we had ended the class with different clinical features of leprosy and also diagnostic modalities for leprosy. So today also we will be continuing with leprosy. So let me begin this class with a small question. How did we eliminate leprosy in India? So before that, let me tell you a definition for elimination of leprosy. As I already told you in the last class, it is very difficult to eliminate leprosy. And that is why we have kept the definition of elimination of leprosy as less than 1 case per 10,000 population. So in India, we have achieved this elimination state, that is less than 1 per 10,000 population in 2005. So my question is, how did we achieve this? So in order to know that, you should know how to control, or what are the different ways to control the leprosy problem in India. So there are different measures which can be adopted in order to control leprosy. So that is what we will be discussing in this class. And the first and the most important measure is medical measure. Following that, there is also social support, there is program management and also evaluation of the control activities. Discussing one by one, first beginning with medical measures. So under medical measures, again, as you can see, there are different steps. That is, first one is estimation of problem. Then early case detection, multi-drug therapy, surveillance, immunoprophylaxis, chemoprophylaxis, deformities, correction, rehabilitation of leprosy patient, and health education. So first one is estimation of problems. Before we begin with any control activities, we have to find out what is the prevalence as well as the incidence of leprosy in any area. So this is done by conducting different types of surveys or epidemiological surveys. And one of the most common epidemiological survey which is conducted is mainly surveys conducted in the school age children. So we go to the schools and we examine the school children for features of leprosy. This is because if the prevalence of leprosy is high in children, that means the prevalence of leprosy among the whole general population is also high. That is why we take this prevalence of leprosy among the children as the proxy for the prevalence of leprosy in the total population. So this surveillance is usually conducted by either Asha worker or Anganwadi worker or the JPHN nurse. So that is estimation of the problem. So when we conduct this survey, we'll come to know what is the prevalence of leprosy in that area, and accordingly we can plan the control activities. So next step is early case detection. So it is very important that we detect any leprosy case as early as possible, because as long as a case goes undiagnosed, untreated, he is at risk of transmitting this Mycobacterium leprae to another person through different ways of transmission. So it is necessary that in order to control leprosy in the population, we have to detect these cases as early as possible and treat them as early as possible. There are different case finding methods. First one is contact survey, second one is group surveys, and third one is mass surveys. So contact surveys are done in those places where the leprosy prevalence is very low, that is less than 1 case per 1,000 population. So what they do is that whenever when low prevalence settings, whenever a new case of leprosy comes, they do survey among all the close contacts and household contacts of this patient. So in order to find out newer cases and treat them as early as possible. Second method is group surveys. Group surveys are done when the prevalence rate of leprosy in that area is between or 1 or more than 1 per 1,000 population. So in this, what they do is that they do survey among a larger group. That is, they go to school, they go to slums, they go to military areas or military recruits, they go to industry camps, settlements, and do a screening. That is, especially they do skin camps. So during these skin camps they can find out newer cases. This is called as group surveys. And third one is known as mass surveys. Mass surveys are done, as the name suggests, it is done to a larger extent or to a larger population. So this is done whenever the prevalence of leprosy is 10 or more than 10 per thousand population. That is, when the prevalence of leprosy is very high. So these are different methods in order to detect cases as early as possible and give them treatment as soon as possible, and so that we can prevent further transmission of leprosy to other people. Next step in medical measures is one of the most important one, that is multi-drug therapy. So earlier only monotherapy was given in order to treat cases of leprosy. Later on, it was especially with dapsone. Later on it was found that people started showing resistance to dapsone. So and also the duration of treatment was very long. Different studies found that if we use these anti-leprosy drugs in combination, we can treat these patients as early as possible within a short period of time and prevent further any drug resistance. That is when the multi-drug therapy was implemented. So different drugs are there for multi-drug therapy. The first one is rifampicin. So rifampicin is the only drug that is highly bactericidal against Mycobacterium leprae. A single dose of 1500 mg or 3 to 4 consecutive daily dose of 600 mg can kill around 99% of viable organisms. The problem with rifampicin is that it can cause side effects include anorexia, nausea, abdominal pain, and occasionally vomiting. And it is also hepatotoxic. Next drug is dapsone. So dapsone has been in use all over the world for more than 30 years. When they started to find the resistance to dapsone, that was when leprosy multi-drug therapy was started. So the problem with dapsone therapy is that there are many adverse side effects, which includes hemolytic anemia, methemoglobinemia, agranulocytosis, hepatitis, peripheral neuropathy, etc. So next drug is clofazimine. So clofazimine is a very good drug which has got both anti-leprosy as well as anti-inflammatory properties. That is why this is also used in lepra reactions. But the problem with the clofazimine is that it can cause discoloration of skin. So some people who use it, their skin will become red in color. Not just skin, even mucous membrane, urine, sweat, etc. So this is unacceptable for some people. So in those places where we can't use clofazimine, we can replace it with drugs such as ethionamide and proteonamide. Other drugs which can be used as anti-leprosy drugs are quinolones such as ofloxacin, there is minocycline, clarithromycin, etc. Next, let's see a table which shows the WHO recommendation for treatment of leprosy. So this is a regimen. First we will discuss about multibacillary leprosy for adults. So in any case of adult multibacillary leprosy, the WHO regimen for treatment or chemotherapy is rifampicin 600 mg. This is given monthly once, and this is given under supervision, just like we have DOTS regimen under RNTCP in order to treat tuberculosis. Monthly once 600 mg rifampicin is given. Along with that, dapsone 100 mg is given, and this is self-administered on a daily basis. This has to be taken. Third drug in multibacillary leprosy is clofazimine. This dosage is 300 mg monthly once, and this is also given supervised. And after that, on a daily basis, 50 mg is given self-administered. If it is a case of paucibacillary leprosy, there is a slight change. We don't give clofazimine. So the regimen is that we give rifampicin 600 mg monthly once supervised. Along with that, dapsone 100 mg on a daily basis is given as a self-administered drug. So this is possibacillary. We don't give clofazimine here. If the patient's age is between the age group of 10 to 14, so in children there is a slight change in the dosage. So let's see what is it. So if it is a multibacillary child case of leprosy, we give rifampicin, dapsone, clofazimine, same regimen, but the dosage is that rifampicin 400 milligram once a month. It is given under supervision. Dapsone dosage is 50 milligram on a daily basis, and it is self-administered. And clofazimine 150 milligram once a month supervised. After that, 50 milligram every other day. If it is a case of paucibacillary leprosy, in a child, rifampicin is given 450 milligram once a month, and again this is supervised. And dapsone is given 50 milligram daily, self-administered. Children less than 10 years of age should receive appropriate reduced ages of the same regimen or same drugs. So next is duration of treatment. So if it is a case of multibacillary leprosy case, drugs are given for 12 months, and this has the whole regimen has to be completed within 18 months. If it is a case of paucibacillary leprosy, drugs are given for 6 months. This whole regimen should be finished up within 9 months. Now there is something called as lepra reaction. So lepra reaction are reactions which occur during the course of leprosy. These are immunologically mediated reactions or episodes of acute or subacute inflammation, and sometimes if not appropriately managed, this can even lead to permanent deformities. So these lepra reactions are usually diagnosed by clinical examination. These reactions are not actually a side effect of any leprosy drugs or treatment. These reactions are also found in those patients who never received any drugs for leprosy. Similarly, reactions should be distinguished between lepra reactions and relapse of leprosy. So a doctor should know how to distinguish between these two. So lepra reactions can be divided into type 1 and type 2 reaction. Type 1 reaction is also called as reversal reaction, and type 2 reaction is also called as erythema nodosum leprosum. Then let's first discuss about type 1 reaction. Type 1 reaction is a delayed hypersensitivity reaction, and it can occur in both paucibacillary as well as multibacillary cases, but usually it occurs in unstable types of leprosy such as borderline tuberculine, borderline, and borderline lepromatous case. So if it is a case of type 1 reaction, skin lesions suddenly become reddish, swollen, warm, painful and tender, and new lesions may appear. Nerves which are close to skins may be enlarged, tender and be painful, and also there may be a loss of functions in those those areas where this nerve is supplied, and this may appear suddenly in case of type 1 reaction. Usually other organs are not affected, and again general symptoms are usually not very much common in type 1 reaction. You can see a photo of type 1 reaction here. So comparing this with type 2 reaction or erythema nodosum leprosum, type 2 reaction are antigen-antibody reaction. This is usually found in multibacillary cases only, that is that too in borderline leprosy and lepromatous leprosy type. In these lesions you can find red, painful, tender subcutaneous nodules, and this ENL or type 2 reaction lesions usually appear commonly on face, arms, legs, and this is usually bilaterally symmetrical. They usually appear in crops and subside within days even without any treatments. Nerves may be affected but not as common or severe and acute as in type 1. Unlike type 1, the type 2 affects different organs such as eyes, testes, kidney, etc. And associated symptoms include fever, joint pain, red eyes with watering, etc. So type 1 and type 2 reaction both are treated with steroids. So steroids like methylprednisolone. Special precautions should be taken in pregnant women, children, those with diabetes, those with ulcers or osteomyelitis, those who has eye involvement, those who has got tuberculosis. These cases, when we administer methylprednisolone, since this is a steroid, it can lead to some complications. So special precautions should be taken while treating the lepra reactions with prednisolone in these cases. Methylprednisolone, usually the duration of course is around 12 weeks, and just like methylprednisolone, clofazimine can also be used in order to treat the type 2 reactions. If there is pain, analgesics such as aspirin can be given in order to treat pain in these cases. Next is surveillance for leprosy. So any case of leprosy, either paucibacillary or multibacillary, even after treatment, they have to be monitored for a period of time. So in order to find out if there is any relapse or failure of treatment for leprosy. So all cases of paucibacillary leprosy, it is recommended that these cases are carefully examined clinically at least once a year for a minimum of 2 years after completion of treatment. Similarly, if it is a case of multibacillary leprosy, these cases should be examined clinically at least once a year for a minimum of 5 years period after the completion of therapy. Next is immunoprophylaxis. So as of now, as a matter of fact, we don't have any concrete tool or vaccines which can prevent or which can be used as a immunoprophylaxis for leprosy. There are certain preparations, especially those made from BCG vaccines, which are under trial for prevention of leprosy. Next one is chemoprophylaxis. So similar to immunoprophylaxis, we don't have any concrete evidence that any drug can be given to contacts of leprosy in order to prevent further spread or prevention of transmission of leprosy to susceptible contacts. So many drugs are under trial or research. Therefore, there's no drugs which are in use in general in order to prevent transmission of leprosy to a susceptible contact or susceptible person. Next is deformities. It is estimated that approximately 25% of patients who are not treated at an early age of disease develop anesthesia and or deformities of the hands and feet. Now, different types of deformities can be found in a case of leprosy. Different organs can be affected, especially organs such as feet, hand, and as well as face. Leprosy is a disease which causes lots of social stigma, and this social stigma is especially due to the deformity which it causes. So there are deformity which are caused by the mycobacterium. Again, there are deformities which are caused because of the anesthesia, due to loss of sensation of particular area, due to contractures of muscle. Because of that, again, deformities can occur. So there are different deformities which can occur on face, that is mask-like faces, that is this patient may look like he doesn't have any expression. There can be leonal faces, there can be sagging of face, there can be lack of thalamus, there can be loss of eyebrows and eyelashes. This is also called as madarosis. There can be corneal ulcer and opacities. There can be perforation of nose, depression of nose. There can be ear deformities, etc. In case of hands, because of the involvement of nerves as well as the cartilages, there can be claw hand, there can be wrist drop, there can be ulcers, there can be absorption of digits, and there can be loss of the extremities. There can be thumb web contracture, hollowing of interosseous spaces, etc. Similarly, in case of feet, again due to similar reasons, there can be plantar ulcers, there can be foot drop, inversion of foot, clawing of toes, absorption of toes, collapsed foot, and swollen foot, as well as callus formation under the foot. Similarly, other organs are also affected, such as testes. There can be perforation of palate, there can be gynecomastia, etc. So these are some of the deformities which can occur in a case of leprosy. So next is rehabilitation. So since these patients are outside from the family, outside from the society, they're not able to do their daily course, they are not able to go and earn and do any work. So there are different types of rehabilitations which can be done for these patients, such as one is physical rehabilitation. For that, correctional surgeries are there for deformities. We can give them crutches in order to walk. We can give them splints for physical rehabilitation in order to prevent foot drop or wrist drop, etc. Similarly, we can also give them medical rehabilitation. We can also give them education rehabilitation. There's also something called as community-based rehabilitation, and this is done with the help of community. This is actually the best type of rehabilitation in which there is involvement of the community also. For this community-based rehabilitation, coordination is necessary from different sectors such as the Department of Health and Education, and also social welfare, and also lots of voluntary health organization help is also required. So rehabilitation is very important in terms of in case of leprosy. And next is final one under medical measures is health education. So in the beginning I told you leprosy is a disease which has got lots of social stigma. There are a lot of preconceived ideas among people and society about leprosy. So whenever leprosy case appears in the society, no one dares to go near him or her. No one dares to touch or treat him. They face this not just from the society, even from their close family members also. So a proper health education is required in order to improve this sad state for leprosy. So proper health education on how leprosy is transmitted. People should be made aware that leprosy is 100% curable disease. Deformities can be corrected. The government support is there. Treatment can be availed from the local health center. This kind of awareness is lacking among the people. And so for this, different health education measures has to be implemented. People need to be made aware about this. So health education should be imparted to the patient, to the family, and as well as the general public. So next is social support. Finding a case of leprosy and treating that case with certain drugs is not enough in order to solve the problem of leprosy. So patients who face problems such as economic problems and social problems also has to be identified and dealt with. So there are various forms of assistance for the patients as well as the community given out by the government and also the non-governmental organizations to give the social support. For example, assistance for the patients to travel to the clinic and come back from the clinic. Giving these patients food grains, clothes, training them to do certain jobs. These are the social support given out to the leprosy patients. So next is program management. So a program was launched by the government of India in 1983 called as National Leprosy Elimination Program. So this program, one of the aim of this program is to eradicate leprosy from our country. So it is because of the constant effort by the government and also the healthcare providers and also the health workers that we were able to achieve a lot. That is, in 1981, the prevalence of leprosy was 57 cases per 10,000 population in India. But this declined to less than 1 case per 10,000 population in 2005. And that's how we were able to achieve elimination of leprosy. There are certain pockets in India and also certain union territories like Dadra and Nagar Haveli which are yet to achieve this target. So we have to constantly work towards total eradication of leprosy from the whole world. We should not stop just in elimination of leprosy. And finally, whenever we implement any national program or any control activities, at the end we have to evaluate what we have achieved through these control activities. There are certain indicators in order to find out whether we have achieved the target or not for control of leprosy. There are certain epidemiological indicators, but there are certain indicators for monitoring of progress of the program. there are certain indicators for evaluation of case detection in the program, and also there are indicators for assessing the quality of services given out through this program. This is how we have already eliminated leprosy in India, but still we are at risk of losing this elimination status in the future. So as I already told you, me, all the healthcare providers, the government and the society should work together in order to control and make sure that this stays controlled and we reach a state of eradication of leprosy in the country as well as the whole world. So that is the end of this class. If you have any questions, you can ask me. Thank you very much.